Hello and welcome. Today, we are diving deep into the knee. You know, it's one of the most powerful joints in the human body. It powers everything from just walking down the street to a crazy athletic jump. But, and this is the big but, it's also one of our most fragile.
And that really is the central question here, isn't it? How can something so strong be so incredibly vulnerable? Well, to get to the bottom of it, we're going to look at its design, which is elegant but also kind of problematic. We'll look at the most common ways it fails, and of course, what modern medicine can actually do about it. So let's start with how your knee really moves, because it's way more complex than you think.
All right, first things first, let's just get this out of the way. Your knee is not a simple hinge, like the one on your door. Not even close. Its movement is so much more sophisticated, and it's that very complexity that gives it both its incredible strength and its greatest weakness.
Check this out. It's called the screw-home movement. As you straighten your leg all the way, your shin bone, your tibia, does this little outward twist right at the very end, and that motion locks the joint into its most stable position. It's kind of like tightening a screw for that final secure fit. Now, why does it do that? It's simply because the inside part of your thigh bone has a slightly longer rolling surface than the outside part. So that little extra travel creates that final locking twist. Pretty clever, huh?
So on one hand, this locking mechanism is brilliant. It gives us amazing stability to stand and walk without our knees buckling. But here's the catch. It also introduces these rotational forces, these unique points of stress that a simple hinge would never have. And wouldn't you know it, those exact stress points are where things tend to go wrong.
And those stress points lead us right to the two most common troublemakers in the knee, tears in the meniscus and tears in the ACL.
First up, the meniscus. The easiest way to think about it is as your knee's personal shock absorber. I mean, this little piece of tough, rubbery cartilage does a ridiculous amount of work. When you're just standing, it handles up to 60% of your body's load. But if you bend your knee to 90 degrees, that number jumps to a massive 85%. It's just incredible.
So you might be asking, how in the world does this small piece of cartilage handle all that force? Well, the secret is this brilliant design feature called hoop tension. Picture an old wooden barrel with the metal hoops wrapped around it. The meniscus fibers are arranged just like that. This design is genius because it converts that downward pressure into outward tension, which stops the meniscus from just getting squished and squeezed right out of the joint.
And this is why the type of tear you have is so incredibly important. A radial tear, one that cuts right across those hoop-like fibers, is like taking a pair of scissors and snipping a rubber band. Pop. The hoop tension is just gone. Instantly. The meniscus can't fight that outward force anymore, and just like that, the knee's shock absorber has failed.
Okay, so that's culprit number one. Let's move on to culprit number two, the anterior cruciate ligament, or as you probably know it, the ACL. If the meniscus is the shock absorber, then the ACL is absolutely the knee's main seatbelt. It's this super important ligament running right through the middle of your knee, and its whole job is to stop your shin bone from sliding too far forward.
Now, unfortunately, the ACL often doesn't go down alone. It can get injured as part of this devastating chain reaction that has the perfect name, the unhappy triad. It's that classic, awful injury where an athlete plants their foot, twists, and maybe gets hit from the outside of the knee. And in one single, terrible moment, three key things can tear all at once: the ACL, the MCL, and the medial meniscus.
So here's a little inside baseball for you. Ligaments don't show up on x-rays. So how can a doctor spot an ACL tear? Well, they look for this fascinating little clue, a tiny chip of bone off the side of the tibia called a Sugon fracture. And this isn't just any old fracture. Doctors call it a pathonomic sign, which is a fancy way of saying it's a dead giveaway. If they see that little chip, there is an extremely high chance the ACL is torn. It's the smoking gun.
So, the damage is done. What's next? Well, let's open up the modern medical toolkit and take a look at how surgeons actually use data to figure out the best way forward for each patient.
For a torn meniscus, the first big question is always, do we repair it or do we just remove the damaged part? And believe me, the answer is not simple. A surgeon is weighing a bunch of factors, but one of the biggest is location, location, location.
Tears in the outer rim, the red zone, have a good blood supply, so they have a much better shot at healing. But a tear in the inner white zone? Way less blood flow, way less likely to heal, especially if you're a bit older. It's all about using data to play the odds.
And what about a torn ACL? Well, that usually means a reconstruction, where they build you a new one, often using a graft from your own body. The two most common choices here each have their own pros and cons. Using a piece of your patellar tendon, that gives you a super strong bone-to-bone fixation which can heal faster. The downside? You might have more pain at the front of your knee later. The other option, using hamstring tendons, usually means less of that front of knee pain, but the tendon-to-bone healing can be a bit slower. It's a trade-off.
All right, we've come to what I honestly think is the most important part of this whole discussion. The surgery can fix the broken parts, but the success, the real long-term outcome, that all comes down to one person. In recovery, you are the MVP.
The road back from an ACL surgery is a marathon. It is not a sprint, and it follows a very structured plan. In the beginning, the absolute first, most important goals are getting the swelling down and getting your leg perfectly straight. You have to achieve that first. Only then can you start building back the strength, getting your full motion back, and eventually retraining your knee for whatever it is you love to do.
So how do you really know when you're ready to get back to playing sports? I'll tell you right now, it is not about a date on a calendar. It's not about 6 months or 9 months. It's about data. And the most important number is this one.
Greater than 85%. That's the magic number. Before you get cleared, your physical therapist is going to test the strength of your quad muscle. And your surgically repaired leg must be at least 85% as strong as your other uninjured leg. This is the key takeaway right here. A safe return is based on hitting these objective, measurable goals, not just waiting out the clock. That is how you stop yourself from going through this all over again. At the end of the day, your knee's future is a team effort. It's you, your surgeon, your physical therapist, all working together. But you have to remember, the most valuable player on that team is you. Understanding the why behind what happened and the why behind your recovery is the most powerful tool you have. So, are you ready to be the MVP? Thanks for watching.